Good afternoon and welcome to this webinar marking 130 years since the establishment of what was then called Sacred Heart Hospice for the Dying and is now known as Sacred Heart Health Services. My name's Linda Newton and I'm part of the team at St Vincent's Curran Foundation. Today we're celebrating 130 years of palliative care at St Vincent's and also 20 years since the St Vincent's Hospital Rehabilitation Service was established in the Sacred Heart building. As we heard from Sister Claire, Sacred Heart opened as a result of a need that the sisters identified in the community. And since then, so many of Sydney's famous and infamous members of the community have interacted with the place, from Mother Dorothea Devine to Tilly Devine, from bushranger Jack Bradshaw to theatre impresario J.C. Williamson, and of course Princess Diana visited in 1996 and met with the AIDS patients here at Sacred Heart. Today's webinar comprises an expert panel who work across the two areas, palliative care and rehabilitation. We've got 45 minutes to talk to our panellists and to answer any questions that you might have. You can type the questions in as you go and we'll try to answer them all if we can. So let's welcome our panellists. Firstly, Associate Professor Richard Chye is the Director of Supportive and Palliative Care at St Vincent's Hospital, Sydney.
Good afternoon.
Richard is also the Area Director of Palliative Care in Eastern Sydney and Community Outreach Services, both locally and also as medical outreach clinics in Wagga, Albury and Orange. So welcome, Richard.
Thank you very much.
Associate Professor Stephen Faux is the Director of Rehabilitation Services Rehabilitation Service, I think it's singular.
That's right.
And St Vincent's Pain Service in Darlinghurst campus. He undertakes research and lectures on pain management, stroke rehabilitation and trauma rehabilitation. He's completed international studies in headache, early rehabilitation, the use of technology in rehabilitation and recovery, and he leads the New South Wales rehabilitation response for COVID-19. Welcome. Liz Davis has been working in palliative care since 1999, first at Calvary Healthcare and for the past 16 years here at St Vincent's. After 10 years in community palliative care, Liz moved into her current role as palliative care clinical nurse consultant, initially at St Joseph's Hospital, which you heard about from Sister Claire, and then at our Darlinghurst campus in 2016. And Val Bramah, welcome Val, is a senior research occupational therapist, starting as a student at Sacred Heart Rehab Service when it opened in 2000. Val transitioned to a junior, then a senior occupational therapist in the rehab department, and also worked as the stroke unit coordinator at St Vincent's Hospital. In her current role, Val works on research trials that involve and impact on the rehabilitation service. Now, it's interesting that when Sacred Heart opened, a lot of patients who came in to die, in fact, recovered and went back home, thanks to the wonderful care they received from the sisters. So, although St Vincent's Rehab Service wasn't established until 2000, in response to particularly increased complexity of surgery at St Vincent's Hospital, I think it's fair to say that rehabilitation of patients began much earlier. So in honour of the care given by those sisters back in the late 19th and early 20th century, I'm directing my first question to you, Stephen. Stephen, over the past 20 years, St Vincent's has helped thousands of patients across New South Wales. What type of rehabilitation services do we offer here at Sacred Heart?
Well, we offer rehabilitation after any injury or illness. Mostly it's to do with the brain and the spine and the nerves, but it equally involves older people with falls and also those involved in motor vehicle accidents. I remember walking into the ward in 2000 with a marker pen and some butcher's paper and an empty ward that was available. And it's now been 20 years and there's been 10,000 people who've been wheeled into the rehab unit and walked home. There's been over 15,000 people seen in our outpatient clinics. We've trained more than 50 rehab physicians and we've also trained more than 2,000 students. So it's been quite a long journey since we started to scratch a few scratchings on a bit of paper. But we have become known in areas such as neurological rehabilitation, and there's a few things about the rehab unit here where I think we picked up on what the Sisters of Charity had done before us, which was we went an extra step. We would do things in our unit that other units would find much more complex and difficult to do. I distinctly remember a man who was homeless, who was had a significant stroke and had lost the ability to speak. And we discovered that not only could he not tell us who he was, he actually didn't have an identity. He had no papers and was only known by the people at the pub where he bought everyone drinks once a week and set up the pool competition. Now, a lot of people would have helped that person just find a nursing home bed, but we went the extra step. We found out that he was from New Zealand and he'd come out prior to visas. We identified him as being suitable for a disability pension. We got him the NDIS, and now he works as a volunteer in our department for other people who've lost their speech. And that's that extra step that that we've been doing here, and that we get support from the sisters to do.
It's very mission-based work, isn't it?
Yeah, I mean, many of the things that we've done here have also involved taking the next step in terms of technology. So I do remember a young man, an 18-year-old boy, who had a brain hemorrhage while he played soccer down here at Rushcutters Bay. His rehabilitation had stalled, and we developed a virtual reality program. He wore a pair of goggles, and we got his MRI images, and we walked through his own blood vessels with him to show him how his stroke had occurred. And there was a sudden pickup in his motivation, and he now completed his university degree. He's travelled overseas, and he's working full time. And
these virtual reality programs, were they initiated at St Vincent's really here? Well, again, you know, you learn so much from your patients. So I remember a professor of engineering saying to me, I've had my stroke, and when I looked in the cupboard to see what tools he had to help me out, there was nothing there. So he introduced me to some engineers, and now we have formal relationships with engineering departments at the University of New South Wales and Sydney University, and we've actually established a centre for research into human robotics at UNSW, and that's how we've developed state-of-the-art devices such as a pair of glasses that detects what people are doing, some inobtrusive sensors that detect whether people are falling, and we've now developed a virtual reality system for the acute pain management, following surgery. So you learn a lot from your patients. I bet you do. Now I'm sort of going not in order now. So Val, just because Stephen's been talking about those trials and you're involved with those trials, yes. So have you been involved with the hands-on trials that for virtual reality Stephen mentioned?
Yeah, we're about to start one of the trials that Stephen mentioned that, yes, I will be involved in with the virtual reality, looking at for people following surgery and their pain management. So we haven't quite started that yet, but we will hopefully start very soon once COVID finishes. Well, yes, so definitely involved, and it's a great time to be involved in research with all this new technology and devices and virtual reality.
Yes. You mentioned COVID, and Stephen, I was going to ask you about the rehabilitation of COVID-19 patients, because we often hear that people are no longer infected, they're no longer in hospital, but that's not the end of the story. No, I mean, in fact, overseas, a lot of people have been talking about the long tail of COVID, where people develop symptoms and have ongoing symptoms, sometimes for as long as 3 or 4 months. We've actually developed our research project since the 10th year anniversary, when donors gave us enough money to establish a research department. And we've been able to attract over $6.5 million into the hospital from that research department. We're hoping that we'll get some funding from the government to establish a sort of office to advise people on what devices and apps and teleprograms to use. Currently, 1 in 3 people over 70 have a disability, but there's 30,000 different apps available for them, and nobody's looked to see if any of them actually work. So we're hoping to set up a department here at this hospital to actually give people an idea whether
apps are worth using, worth buying, and will be helpful to them.
Is there an app for recovery from COVID?
Well, there's a number actually.
Okay.
Yeah, there's a number.
All right. Now, Richard, obviously not all patients can be rehabilitated. They've either come to the end of their natural life or they have a terminal illness and they need a different type of care, and that's the care that you and your team provide. Can you explain to us how you define palliative care?
I think you've noticed that we've actually changed our name. It used to be called Sacred Heart Hospice, and then became Sacred Heart Palliative Care. And as Anthony mentioned just now, and also Paul McClintock, called it Sacred Heart Supportive and Palliative Care. And that's the range of change that has happened. I do remember a researcher at our own Garvan Institute who was trying to regenerate heart cells for patients who have heart failure, who have developed a heart attack. And he actually said on the ABC radio, there's only one way of curing, and I use the word curing heart failure. And he said the only one way is by heart transplantation. And that's what St. Vincent's does so well, don't they? Then he also led me to think, well, what about all those patients who don't have a heart-lung transplant, who haven't got a transplant, but they're still in heart failure? What are our cardiologists actually doing then? Well, they've been providing assistance with their breathlessness. They've been trying to improve their swelling in their legs. They've been improving their ability to do things to reduce their breathlessness. And how do they do it? They use diuretics. They use hard drugs like beta blockers, ACE inhibitors. Why were they doing it? Because they were trying to improve the patient's symptoms, trying to improve their quality of life. And that, for me, well, that was palliative care. That's what we do. We use medications to try and improve the symptoms of our patients. Yes, our cardiologists use a diuretic, and I may use morphine, but we're basically doing the same thing. In other words, palliative care starts from when an incurable illness has been made, a diagnosis of an incurable diagnosis has been made. And that could be 30 years before the patient passes on. A patient who's developed renal failure has 30 years, decades of renal dialysis ahead of them. Why renal dialysis? Is because it prevents the symptoms of renal failure. Yes, that is not provided by palliative care services. It's not provided by me or my team, but it's provided by everyone here at St. Vincent's Hospital. When we're not able to cure illness, we provide the best quality of life for our patients. And that's what palliative care is. Supportive care has gone beyond that in terms of, well, there are symptoms associated with the dialysis. There are symptoms associated with chemotherapy, symptoms associated with radiotherapy. We are very skilled, and my team is very skilled in looking after the symptoms of cancer. We are also very skilled at looking after the symptoms associated with treatment, and that's what is supportive care. And going beyond that, that's why we're looking at patients not only with cancer, we're also looking with patients with heart failure, with lung failure, with renal failure, with liver failure, and also ultimately with aged care as well, because we are looking after patients who are frail. And eventually, yes, we may come across patients who will not survive COVID-19 at St. Vincent's Hospital, and we'll stand ready to be able to provide the same compassionate care for those patients as the same for all the others as well. Not only here at Sacred Heart, but we're also making sure our services are available for patients who want to pass on at home as well. And that's an important part. So yes, palliative care and supportive care has changed a lot in these last 30 years. And yes, I've been doing palliative care for 30 years now.
What drew you to palliative care, Richard?
I think there are three main reasons. One was my father, who died from kidney cancer, and I have to say in the 1980s, where palliative care was not very well accepted, I think his death wasn't very good. I was also interested in medical oncology in my early days. And when I compared medical oncology and palliative care, in medical oncology in those days with treatment, I was making a lot of patients very sick from treatment. And when I worked in palliative care, I was making these sick people much better. And I found a lot more satisfaction in that. And the people who trained me could also see that was my passion as well. It was not so much about treatment, but it's actually about looking after patients. And that's why I moved towards palliative care. And that's what I hope to do for over the next decade or so, for the time that I have working here at St. Vincent's.
And what do you see as changes in palliative care over that, say, the next 10 years?
I think that more palliative care will start as doctors recognize what we can offer early in the course of disease, early in the course of an illness. And so we're seeing patients much, much earlier in the course. Yes, it may be some that may be in the last few days of life, but a lot of patients, more than 5% of our patients, are still alive after 12 months, and we still look after them. And we have patients who've gone for 10 years because they may have complex needs that need looking after from the ravages of their illness, from the ravages of the treatment that they have. They all still need the same care. So a lot of it is providing that type of support for patients early in the course of disease. We also recognize that, especially from a cancer treatment point of view, where treatment is so much more easily tolerable, that our patients are getting treatment later in the course of the disease and being in the acute hospital. And so we've set up to make sure that palliative care does not only happen here at Sacred Heart, it happens throughout this campus, even in the acute hospitals. Even when patients are having surgery, we're still there with our patients. And as you know, who wants to be in hospital? They rather be at home, don't they? And so we want to make sure that we're able to properly support and safely support our patients at home, to also support their families, their carers at home, to support the people around them. It's not only me about looking after my staff to make sure my staff are well looked after, they're well refreshed, they're well trained, but I can tell you from personal experience, when I am tired, if a family member is tired, then I'm not going to be able to look after anybody. So looking after patients is important. Looking after family members at home so they can look after the patient becomes so much more important. So in palliative care, it's not only just the patient alone, it's all those people around the patient and all the other people around those families that I try and support to make sure that the patient in the middle gets the best quality of life.
Liz, I'm going to ask you, because you're at the coalface of patient and patient carer world, particularly in the community. How do you see your role in that context, and how do you deal with the demands of the competing needs of the patient and the carers and the community, and those also who don't have family, they're not able to have palliative care in the home?
And yes, predominantly my background is in community, but I work across the campus here at St. Vincent's. I think what I've always sort of said, I've been working in palliative care for 20 years. Palliative care is changing, as Richard has alluded to, but I guess it's just trying to make people aware that palliative care is everyone's business, that it isn't just reliant on our service, that we have a role to educate and communicate. And I guess a lot of it does come down to communication, and be able to communicate with families and clinicians, supporting nurses through this process, because it can be very challenging and difficult. I guess having the resources available to you to offer that service. Palliative care has changed significantly. When I first started in palliative care, a lot of the stuff that we did we did because we didn't have any clinical evidence to support it. We did it because that's what we did. But now, we have a research unit here, which Richard is, and other clinicians that I work with. I mean, it's very, very positive. And I think sometimes people see us as an us or them, or it's either or. But we can, as Richard says, we can work alongside other clinicians to provide good quality care, provide good symptom management for those patients and their families and the significant others that,
So it's an area of work that one could consider might be depressing or get you down. And do you find that? How do you stay positive, and what drew you to it?
Yeah, sure. You often get, it's certainly can be a conversation stopper when you say, introduce yourself, I'm a palliative care nurse, and you can see, okay, what do you say next? It must be very depressing and sad, but I think it's more than that. Obviously I'm very passionate about it. That's I've been doing it for such a long time. Being able to experience and witness someone and support a family and a patient through that experience is a very humbling experience, and I think it's a privilege, because often you're sharing someone's very intimate moment with them and their families. So to be able to support them, the patient and their families, I think it's very rewarding. Yeah. And obviously being able to have support, and we've got a really good team here, knowing that we can talk to someone, and looking after yourself, having that, being able to have that time out to, hey, take a breath. Yeah.
It's getting that balance right.
That's right. Yeah.
Which Richard talked about, making sure that you're looked after,
correct,
as well as your patients.
Yeah.
Val, I'll just ask you now that you're in quite a specialist area of occupational therapy, which is research trials.
Yes.
How did you become involved in this? Is that something you wanted to do from an early age, or?
No, it was definitely not something that I started going into occupational therapy thinking I'm going to be a researcher. I obviously started here at Sacred Heart as a student and worked through as a junior OT, senior OT, and then went to the acute stroke unit, coordinated that, which was where I guess I started to get an idea of research really there. It was a clinical and administrative role, so started to be involved as a site in national, international and local research, and also collaborated with Rehab while I was still over there to develop research projects. And so that's how I started to understand what research was about and how this too could obviously help patients and achieve good outcomes. I did actually then leave St Vincent's for a little bit. I moved overseas, but did come back to where I started, and obviously was lucky to get a role as a researcher here in the same sort of amazing department, innovative team, to try and continue with this research to help rehab as a whole, not just occupational therapy now, but rehab as a whole. So yes, quite specialised, but still have my occupational therapy hat on, still get to use my clinical skills and clinical judgment in developing research trials that will overall help the patients and get better outcomes for rehab patients.
In terms of trials and technological innovation, I guess, it's almost as if the sky's the limit with technological innovation, is it?
Yes, it is, and technology is obviously the pertinent topic at the moment, and especially with the world of COVID, that we've all had to quickly jump and use technology. Yes, it is the world, but I think being in a research role, it is also very important that we research, that we are actually using technology in the right way, and for the right populations. I think that we have amazing populations of patients here that come from different diverse backgrounds, have different medical needs, and not all technology is going to meet those needs, and particularly a vulnerable population that might not have access or ability to use technology. So we just have to be careful that yes, there is amazing technology and devices, but we do need to research it, which is why we are here and hopefully going to use research to get outcomes to guide us in how to use it. But yes, technology is amazing. And certainly from when I started here in rehab, we had a very simple computer using a program to help with upper limb rehab, and things have changed dramatically. So I think we're lucky where we are, and certainly will benefit a lot of patients, the technology that we can use. Yep.
Now, both the rehab and the palliative care teams have mentioned coronavirus, and I'm assuming, Richard, that you mean it you meant it in a palliative end of life situation when people have perhaps recovered from being infectious but are not going to survive?
No, I think COVID-19 is an illness that causes a lot of morbidity in patients, and unfortunately, because of a patient's background illness, there may be times when the body's not able to withstand or tolerate the ravages of the virus, which ultimately may lead to their demise. I think that the chances of that for the majority is very low, but I think if that were to happen, then we stand ready to be able to look after patients when they are dying from COVID-19. We stand ready to support the families who obviously will be very shocked because things do deteriorate sometimes very quickly, and there's very little time to plan, very little time to talk about things that they're going to miss. COVID-19 also means that we're going to have to separate sometimes patients, staff, but also family members, so that infection doesn't cross over to people who are not infectious, family members as well. So St. Vincent's is putting up a lot of technology to ensure that patients are still able to connect with their loved ones. Maybe not in the bedside, but the majority will be, for example, using lots of iPads that this hospital has been able to procure and get ready for that time. Yes, the most important people will be allowed at the bedside, and that's what we're pushing for. But not everybody is going to be able to do that. So in a way, yes, we are getting ourselves ready from a technology point of view for the end of life for COVID. But I think that the numbers will be small for those who need our service. The majority, I suspect, will be absolutely fine and recover. And yes, there will be patients who will require Stephen Faux and his team's support to recover from the COVID. And I think that whilst I worry at the moment that a lot of young people, and like all of us, are being very complacent, and whilst a lot of young people believe that they will be able to get over COVID-19 without any problems, which I agree with, my main worry is that if they get infected, they bring it back to their homes, they bring it back to their households, and they may infect someone who is a bit more vulnerable in that household. So it's not about the messages for young people for themselves, it's about trying to prevent the consequences of infections later on. And that's my main worry. And also what the long-term effects of COVID are likely to be or could be. As Stephen said, there's a long tail to it. And we need to be able to prepare for that as well.
Stephen, yes, you mentioned rehabilitation of patients once they've recovered, and I've read about having to learn to breathe again and use their lungs again. Can you tell me about that and your experiences here at St. Vincent's with recovered patients?
Yes, well, I mean, thankfully, New South Wales has been doing a great job, and it's mostly because we've planned. We've done a lot of planning, and when things happened, we were able to get on top of that. But there is a long tail to it, because COVID is not just a respiratory disease. It affects the brain, it affects the spine, it can increase the number of strokes, and it causes difficulties in walking and difficulties in being able to feel things in your hands and feet. So there's a number of waves of COVID. At the moment we're talking about a second wave of community transmission, but when we looked at it early on, we said there were 4 groups who were going to be affected. the people who got it, the people who have chronic diseases who were frightened to be admitted to hospital, and that's exactly what we found. Stroke patients didn't come in, so they couldn't get clot busting treatments, and they ended up coming to rehab requiring a lot more treatment. And then there was another group who rely on this hospital to keep themselves fit and active, and they couldn't come because of COVID, and they deteriorated and fell. So the number of people who fractured their hips after falls went up. And then, of course, we're seeing now the impacts of mental health on people who are fearful of leaving or develop depression because they can't get out and see people. And our mental health services are working over time. And I did want to pick up on something that was said earlier, just a little bit about teams and about the importance of managing staff. One of the things that actually links palliative care and rehabilitation is the use of teams. I always talk to students about rehabilitation teams are like a pit crew at the races. You come in and all your wheels get changed and everything gets happening pretty quickly. But it wouldn't work if everyone didn't know their job and didn't work carefully and well with each other, and exactly the same I imagine for palliative care. If the teams don't work well together and they don't look after each other, they can be fatigued and wouldn't work well. At the time we came here in 2000, teamwork wasn't very common. In the last 20 years, it's developed so much so that Medicare has now recognised team cooperation as worthy of payment. And now we can see our acute colleagues working out that, yeah, you have to work as a team. The cancer services work better as a team. The coronary care services work better as a team. The stroke services work better as a team. So keeping a strong team together is actually the value of the service. And it's the people. I always say, you know, don't look at the bricks and mortar, look at the people. You know, if they're working together, if they're happy, then the service and the outcome's going to be fantastic. And it's the same with COVID. If we can work well with our acute colleagues, if the intensive care people call us early, we can get better outcomes for people. If they call us late, when people already have problems walking or breathing, then our outcomes, they're harder to achieve. Yeah.
I must say that from a personal perspective, our hospital's response to COVID-19, I've never felt prouder to work for St Vincent's, and I've never felt more part of a team than I have since we went into, you know, preparations for COVID. And that's probably where we'll finish the questions from the team, and we have some time for questions from the audience. So I've got some waiting for a question on the screen in front of me. The first question is, and it's really for anyone who wants to answer it, were there lessons learnt from either the Spanish flu or the AIDS epidemic? That, you know, one pandemic that's been around in our lifetime and one before that. Anybody want to jump in?
Well, I think the Spanish flu,
The
Spanish flu's very, you know, I looked at some old photos and guess what they were doing? They were washing their hands and wearing masks. So one of the things I guess that wasn't around, or people didn't realise at the Spanish flu that we've learnt, was the importance of social distancing. There was a tram, a famous tram that used to go up Bondi Road once a week to take people to the infectious diseases hospital at Prince Henry, and I remember there was they would bring out people who were deceased from inside their homes. They hadn't worked out how they hadn't worked out the risk of infectivity and how quickly that had occurred, but now we're on to that, and it's working in New South Wales and New Zealand and a whole variety of other places.
I think that the messages, especially from the HIV pandemic, is about how we convey the messages about the virus, how we convey about its infection. I think that trying to provide the message is the important thing that we've learned and are still learning, unfortunately. We're still learning about making sure that we get the right messages about how to prevent ourselves from getting infected. Yes, washing hands, for example, is important. Keeping our social distance is important. Coughing into our elbow is important. Everybody thinks mask is the right answer. And the answer is no, it's not. The mask is actually your fourth line. It's after the hand washing, it's after the coughing, it's after the social distancing. Those first three are the four most important things. The mask is an extra. And the mask is important for us because it actually prevents someone wearing the mask from infecting someone else. It doesn't prevent me from getting getting an infection. If someone coughed over me, the mask doesn't stop me from getting an infection. It's only when I have a face shield and a mask and being gowned up, yes, that will protect me. So the mask is about protecting the community. The mask is about making sure that people who have no idea that they're infected, that they may give an innocent cough, that the mask is there to prevent infection from going elsewhere. But it doesn't mean that the hand washing, the coughing, and the social distancing are to be put aside. No, that's the most important thing to prevent COVID-19 for all of us. In our hospitals, all our staff are wearing masks, in addition to making sure the social distancing, the coughing, and the hand hygiene is up to 100%. That's what we need to do. And that's why our message as well is that, yes, if you come to the hospital to visit a loved one, please follow the instructions at St. Vincent's Hospital, and in fact, any other hospital in New South Wales for that matter, is because what you do protects staff, you help staff, because without that staff, without the health worker, without the nurse, we have no one to look after patients who are sick.
Well, we've
That's
seen that particularly in nursing homes or parts of Victoria, the sadness of that. And in terms of the HIV, from my perspective, it feels that because there are a lot of people who work at St. Vincent's still, including our CEO, who worked here during the HIV/AIDS crisis, and it felt that we knew firsthand what that was like, and we got on top of COVID-19 really quickly because we had people here who were there in the HIV, and we were right in the heart of where HIV struck. So it felt that we were super ready as a result of that. Now, I had another question, and it might need to be our last question. Could Richard or Liz comment on spiritual, psychological, and existential symptom management of patients with incurable diseases? Liz, would you like to just give a short comment on symptom management from a non-physical perspective?
And I think that's a really important question, and it is quite a challenging symptom to address. But I guess we're fortunate here that we've got psychological support through clinical psychologists, social workers, to provide that support for that existential distress that patients experience coming into their terminal illness or the terminal phase. In regards to symptom management, we have an armour of medication, but it's often having the support of their loved ones nearby. Yeah.
It looks like Richard and Stephen agree. Richard, did
I think that existential distress comes from a normal reaction when facing an illness. The question of why me comes to anybody's thinking when they have a diagnosis. They're also worried about, if I'm not here, what else can we do? What else am I going to who's going to look after my children? Who's going to look after my father, my mother? All those questions are very, very normal questions. And as Liz said, yes, we may use morphine to help our patients with pain and other medications, but trying to deal with the distress from a diagnosis is just as important. And therefore, having the psychological team here to be able to provide that support. When we talk about
teamwork, doesn't it?
That's right.
Yeah.
In terms of technology, all of us recognize we all have a bucket list. So I'm working with Stephen to see how we can ensure that our patients actually tick off those bucket lists. Because if that's a source of distress, that I can't do X, I've never been to the Grand Canyon and I wish I would, but I'm now too sick. I'm now enlisting the help of Stephen and his rehabilitation team to see how we can put that virtual reality to be not virtual, but more reality for our patients, so that they don't lose and miss out on experiences that they wish they had. And then one way, working together as a team to solve some of the existential distress.
Yes, it's a really interesting area, and we could probably do a whole webinar on that, but I'm being told we've run out of time. So if anyone did have questions that weren't answered, we will get back to you over the next few days with your answers. So I'd like to particularly thank Richard Chye, Stephen Faux, Liz Davis and Val Bramah for taking time out of your incredibly busy schedules to provide your expertise and your insights today. I'll also mention that St Vincent's is actually publishing a book on the history of Sacred Heart. It's written by our archivist Anne Cook, and it's been generously supported by David Hall, AM and Helene Hall. So it's going to be a fascinating collection of stories and photographs, and that'll be coming out early next year. If you're interested in supporting either palliative care or rehabilitation at Sacred Heart, or indeed any area of St Vincent's, you can hop online and make a donation at supportstvincents.com.au, or you can call the Foundation office. Those details will be up at the end of this. And I'd again like to reiterate what Anthony said about the special value, the incredible impact that gifts in wills have made throughout the history of Sacred Heart, starting with the bequest of £2,177, 8 shillings to help buy the land to build a bigger hospice. So that's, if you are interested in leaving a gift in your will, please give us a call. So thank you everyone, and thanks to our audience who joined us today. Bye-bye.
Thank you.
Thank you.
Thank you.
Thank you. Thanks.